So I'm going to try and just briefly introduce you to this area. It covers a range of specialities. I worked as a clinical psychologist, originally training just to work in clinical work, but in later years I found myself being more interested in research and then eventually in teaching and training. So my last post for the last 20 years has been running the doctoral training course in Oxford to train new clinical psychologists. So what I'm going to try to do is really talk to you about what it's about and what we're trying to do as clinical psychologists. And I suppose the best place to start is, if you like, what I often say to my own family and to myself, which is it's actually tough being human. Being a human being is difficult. We have so many differences and difficulties to deal with in our lives, complex feelings, emotions, desires, challenges throughout life, managing other people, managing ourselves, managing the world around us. So I've always been interested, how do people do this? How do people tick? And what happens when it goes wrong? And there have always been difficulties in life. We are not unique in finding life sometimes problematic. If you've never experienced emotional difficulties or relationship difficulties in your life, then you're incredibly lucky, and I think you're probably quite rare. Sooner or later in your life there are things which go wrong, and I'm not going to talk in great depth about any individual case, but later on in my talk I will talk about a couple of examples of people I've worked with. But it's tough managing all the things you have to do, your ambitions, your needs, your family, your parents' pressures, and the world around you. And that's always, as I say, always been the case, not just now in this century, but in many other centuries. We know that there has always been, not everybody finds it easy just to get on happily in the world that they're born into. And there have always been ways that society's had to offer people some way of feeling better about themselves and other people when people find things difficult. And I've just listed historically a range of ways in which society has offered people who are struggling a bit. And there are many ways of dealing with distress. So if you like to start off as a law, people who behave differently or oddly, we deal with them legally. We put them in a class, maybe that's somebody who's behaving badly, we put them in prison or we put them away somewhere. So the law deals with people. And to this day, when people start behaving strangely in the street or something happens which is challenging, we may call the police or a lawyer to deal with that. That's one way of dealing with people who are behaving differently. Another way, of course, is medicine, and medicine has always been a place, and nowadays we tend to turn to, if you're unhappy, go and see your GP, and maybe they can find some way of helping you with that. Other ways include religion, and some way that if you like, you can go and see your priest, and typically and historically, these three methods, the law, medicine and religion, have been the way that people have dealt with feeling low, having difficulties, children behaving who are challenging, behaving in ways which we want to change. Those, if you like, those are the big ways in the past that people have dealt with difficulties. I've also put magic there because, again, another approach is, for example, using astrology or some other sort of technique to deal with people who are behaving strangely or feel bad about themselves. And to this day, you can look up in your astronomical signs and look up read the future. People still use that as a way of making themselves feel better when they're not happy. I mentioned politics there again because changing society is another way of trying to change people's emotions and ability to get on with life. If you like, those have been the big ways in which in the past we've dealt with distress. But increasingly, and certainly since the 19th century, people have tried to understand the mind. People have tried to understand what's going on inside our heads. And the science of psychology has developed. And that's the background to clinical psychology. And I will just briefly mention what that is. Any of you, psychology is now the most in-demand undergraduate course in the UK to do your degree in, and it's the most competitive, one of the most competitive degrees to do. And it's a study of human experience and behaviour. And very quickly, I've run through some of the things that happens within psychology. In order to become a clinical psychologist, you study this first. And the kind of things we study is how is it we learn things, how memory works, and importantly, how we forget things. That's a very important part of the system. What stress does to us, and how we are different from other species. How hormones operate on us and how, for example, drugs and alcohol work on the body and the mind. Why do we sleep? Why don't we sleep? And what it is, how the perceptual system works, how the brain sees, feels, and how emotions work. Perception, how perception works. How we recognise people and how we attend to other people or to anything else. And how we make judgments. So the whole way in which the brain works is the subject of psychology. And as a science, it's really quite recent. It's maybe 200 years or so, but the most progress has been made within the last 50 years. Other things psychology does is why we have emotions, why we feel, and particularly child development, how children learn, how they learn social behaviour and language, and how people attach to one another, and how important relationships are. How children separate when they eventually do, what that process is and how important it is, and what the effects of ageing are, how we get along, how we behave differently socially with other people, and how groups differ from one another, and why we get on with other, how we get along with authority. Those are just a sample of what you study in psychology. So that, as any of you might have done a psychology degree, this will be familiar to you, and this is the equivalent, as in medicine, of studying genetics, physiology, and anatomy. So if you want to be a clinical psychologist, you do all this first, so you have a notion of how the human mind works and how people behave. So that's our bread and butter. So that, if you like, is the degree that I originally studied. But I was most interested in what when it all goes wrong, when people are unhappy, and what happens during the periods of life when most of us have some challenges. What can we learn in the same way as when you do anatomy and physiology and genetics, if you're a doctor, if you understand that, well, what is it when it doesn't work? So clinical psychology, which is, as I say, my interest, is the application of psychology in clinical settings where people have emotional or psychological difficulties. And these include hospitals, in particular mental health, but also child health, and also or clinics wherever people present with psychological distress. So clinical psychologists work in a variety of different places. My early years in the 1970s, 80s was working in psychiatric hospitals, but people also work in general hospitals. So it works across the lifespan from infants, so how people may have difficulties in early relationship attachments and things like adoption and some of the kind of difficulties that children can experience, and the relationships between parents and babies, through to the very old and the process of letting go of life at the end of life. Now, we, as clinical psychologists, you work very closely with medicine, and I mentioned the training to become a doctor. One of the things you can do, one of the specialties within medicine, when you've done your basic training, you can choose to do is psychiatry. Now, psychiatry is different from clinical psychology in that to be a psychiatrist, which in fact our daughter is, you have to do medicine first. So she's done the whole business of anatomy, physiology and all that stuff, which I didn't do. So she's very familiar with, and psychiatrists know about how the body works. And their treatment of mental health problems tends to be oriented towards the physical. So, for example, the treatment psychiatrists tend to give, if you're suffering from depression or stress and you go see a psychiatrist, they will tend to, first of all, they'll do a very thorough physical examination, and they may well give you some medical treatments, for example, antidepressants or some other sort of physical treatment for your condition. Now, I'm not qualified to do that. I'm not a doctor. I wouldn't do that. But I work very closely with doctors so that we will see people where perhaps medical treatment isn't appropriate or it's not thought to be helpful in this case, where we have a close relationship, we cross-refer to one another. But we have a different treatment. Our treatment is psychological, not physical, though I'm very aware, of course, we have bodies and therefore hormones and things are important. And drugs do have an impact. Indeed, there's nothing wrong with psychiatric treatments like antidepressants. They can be used very much with psychological treatments, so we work together. So particularly psychiatry, and we offer a different perspective. So by and large, the model underlying psychiatry, underlying it, is a physical one, which is there's something wrong with your hormone balance or with the endocrines or the brain chemicals, so you can fix it with medication. Whereas we'll understand when people have distress, depression or personality relationship difficulties, or children behave challenging ways, or families break down, that it isn't an illness that's happened to you, though that's a convenient label. It's not an illness, it's a complex human response to trauma or challenge or difficulties. So what's wrong with you is while we can treat it medically, and often those treatments help, interestingly, they do help, the cause may be something else. So by and large, what we do is help people to develop solutions to their problems rather than if you come and find a medical way of fixing it. But again, we do work with doctors, and if you do have depression, often the very first useful thing to do is to try antidepressants because we know they're effective. And if they're effective, fine, because you can get back to work and that's great. But if it doesn't fix it, or you don't want to use antidepressants, often a psychological approach is the next step. To complicate matters, many psychiatrists also use psychological treatments. So they will use the methods that I might use, but I won't be prescribing because that isn't my background. So we do work with them, but our speciality is the psychological, based on all that research, all that knowledge, to do with how people think, how people perceive, how people develop, all that stuff I mentioned earlier, which is our kind of basic stuff. So we work with people to try and develop a solution to the problem, and based very much on a collaborative relationship. So patients are referred to clinical psychologists usually because they go to see their GP, or somebody suggests they need a bit of help, perhaps because they've got difficulties in the family, the child is repeatedly challenging or difficult, or the child is very anxious, or perhaps the adult, you or me, and it's very much like all of us could be in this situation, feel depressed, feel anxious, have difficulties in our relationships, or maybe granny is getting more and more challenging to us, living at home with us. We don't quite know how best to help the family to adapt to the fact we've now got granny living with us, and that's difficult. We've also got a teenager who wants to go out drinking, and all sorts of problems. These are human problems, which aren't illnesses. Can we find a way of solving it? And we very much work with people who bring their problems to us and tell us about them in confidence. Because it's confidential and collaborative, ethics is very important to us, so we have a very strong ethical code. We are regulated by the Health Professions Council, which is like the General Medical Council, and we also have a professional organisation, the British Psychological Society, which has codes of ethics that we have to abide by. And these specify very clearly that we're there to help the patient, not ourselves. And that's important because typically what happens is that a patient will come to see me, and I should mention I've mostly worked with adults, will come to see me with a problem, a difficulty, and will trust me, hopefully, with telling me some very intimate personal things. And my responsibility is to help them the best I can to solve their problems, not because I think I've got the answer. I've got to help them work out the solution. And if you like, this little cartoon summarises it. We're encouraging people to become involved in their own rescue. I don't think that's very ethical there. That man is busy reading his comic book while the person's drowning. We wouldn't quite do that. But we certainly don't come up with answers for people because there isn't any point in that. We don't have an answer. We help people to think differently and to help them to see how they've got into the situation they're in when they're feeling muddled or they're feeling upset. So it's we are a helper, if you like. We work with them to change the situation. So the kind of people who go and see clinical psychologists, these are typical clients, people with phobias, so fears, which are very common, or anxiety. These are, in a way, some of the easiest problems to solve. If you've got a fear of lifts or wasps or spiders or cliffs or something, aeroplanes, those are quite relatively straightforward difficulties, and often that's to do with people over long term avoiding discovering those things are actually quite harmless. So that's a very common difficulty, very common amongst children. People often grow out of them, but again, people can get stuck. People with depression, that's a more complicated problem, and there are lots of reasons why you might experience depression. Life is challenging for you. We can't solve that. Life is difficult. Life is tough, remember I said, but we can maybe help you to understand that ways you've tried to solve your depression are paradoxically not helping you. So things like relationship problems, people who've got, again, stuck in things which are difficult, needs another perspective, people with eating disorders, and psychosis. Psychosis is, if you like, how we tend to use the term now rather than schizophrenia or manic depression. Those are words we tend not to use so much now because we're much more thinking about what's going on in the mind. Psychosis is disordered thinking. We're starting to understand it better now. Based on lots of very good psychological research. But very serious mental health problems which are very challenging and very disruptive to people's lives. People who have long-term difficulties in the past used to be hospitalised, but now we have better ways of managing it, together with psychiatrists who have better drugs to help. Also people with physical illnesses like cancer, stroke or spinal injury. If you have a life-threatening illness, it affects the way you think and feel, inevitably. And children with a range of family and individual disorders of different types, difficulties in relationships, school refusals, disruptive behaviour in the family, or child anxiety, which is very common. And people with brain injuries and developmental disorders, all of which have a psychological component. You can't just have, say, diabetes or a stroke or heart disease without it also infecting how you think and feel. So we use a number of models. Some of you have heard of CBT, that's very common now. The cognitive model says the thing let's pay attention to when there's a disorder or unhappiness is how you think. So we look at how it is your understanding, your perceptions of what's going on. The underlying idea here is that sometimes people can understand something in a particular way which leads them to have particular emotions. And what's difficult is the way they're thinking. When you are depressed, for example, we know when people suffer from depression, they tend to think in more concrete ways. They jump to conclusions. They'll see things in more black and white, which can lead you to make assumptions about the world. And I'll come back to that in a minute, but that can aggravate your low mood. So when we're working with depression using a cognitive model, we try to help people to see how their thinking is actually unhelpful to them. Behavioural people, we use treatments, for example, say with children, whereby we help people to train how they behave, and again that leads to different consequences. CBT is a combination of behaviourism and cognitive therapy, which is increasingly popular. A lot of evidence suggests it's very effective. Psychodynamic, this is more Freudian thinking, try to understand relationships and particular attachments, and difficulties people have with attachments. And what I call systemic, this is trying to understand how the system around you, perhaps at work or in your family, is aggravating your difficulties. So we'll use all these models. The way we work is if you like, a series of stages. First of all, the person is assessed. So a person seeing me, I will ask them about what's happening to their lives, what's happened to them, what's the history of the problem, what's going on in your life, who's in your family, are you working, what else is happening to you. So we might use questionnaires or just talking to somebody. And we might pay attention to how they are in relationship with us. So are they very challenging or are they very passive? So we'll pay attention to those things in the room, in the assessment room. We'll then come up with a formulation, which is a bit like the diagnosis in medicine. And in particular, we're interested in the predisposing factors. Why does this person have this problem here? And is there something in the background? Perhaps they come from a background where people were anxious in the family. What precipitated it? What happened last week or a month ago that led to it happening now? And what is the presenting problem? What's going on? Why is it staying there? Why is it perpetuated? Why haven't people don't want to be sick or ill or unhappy? Why is it going on? What's going on? Why is it perpetuating? And if you like, what is going on which is protecting them in their lives? Everybody has some good things. So have they got good relationships? Have they got a good job? Have they got something somewhere which is also helping them to manage? So we need to know all of that. We then come up with a formulation which is like a diagnosis, and I'll show you some formulations in a minute. We then do it in agreement. We'll draw up a plan to intervene, to change things. For example, if we're using a cognitive model, we might set about a series of cognitive experiments, helping them to think differently about whatever the problem is. Or behaviourally, we may set up, again, some little experiments to do with the person. Just an example, someone who's frightened of going up and down in lifts, they're frightened that something catastrophic will happen, very scared of going near a lift. You have a lot of lifts, you'd have to walk up and down the stairs every day, it'd be a pain. So what we will do is help the person who's very frightened of this, first of all, watch me going up, trusting me, I'll go up and down the lift, they'll watch me doing it, then eventually we'll stand inside the lift without closing the doors, and they'll get used to that. Next time we'll go inside, perhaps they'll go up together on one floor, which is very scary, but I'll be with them, helping them to relax, helping them to experience less tension. And then the next time we might get them to go up 3 floors, and finally to go on their own, up and down. So that would be a very simple behavioural treatment. If it's a relationship problem, it's not quite as simple as that, as you can imagine, but we would come up with some other ways of suggesting an alternative. We then evaluate, did it work, didn't it work? If it didn't work, go back to square one, try something else. At the same time, we're doing research because we want to make sure we have the right treatments for the future. How we tend to work, well, it takes about 8 years to train, to see somebody. So as I say, a degree in psychology first, then we don't like to take somebody straight off because they're very young and a little bit inexperienced when you're 21. So we often ask them to go and get some work in the workplace, maybe in hospitals or somewhere where they're working with people to make sure that they get a bit more experience. We then do a 3-year doctorate, so that's why it's around 8 years altogether, which is what my last job was doing that, training people. Our model underlying is science practitioner. In other words, we are practicing, we're not in labs, but we are using the notion of science because we test something, does it work, doesn't it work? If it doesn't work, we try something else. We're always measuring, has it worked, what's the outcome? So we get people to fill in questionnaires, drives them mad, but we need to do that to make sure we are on the right lines. And we use research-based evidence trials, which indicate what works and what doesn't. A lot of a role for that. We spend a long time reflecting. We need to make sure we're behaving ethically and we're aware of the context of what people want to do in one context with one ethnic grouping might be different from another one. When in the UK, this is pretty much based in the NHS. Our training is funded in the NHS. In the rest of the world, it's very different. People very much self-fund their training and work privately. There's a little bit of private work in the UK increasingly, but I've never worked privately myself. I've spent all my life in the NHS or in academia. If you want to see a clinical psychologist, they do advertise. They're increasingly working privately. Normally it's people referred by GP or another medical specialty. So, for example, a renal specialist might say, this person's having difficulties adapting to the need to be on dialysis, can you help them? Or this person's had a brain injury, let's work with them, with their families to help them back to normal life. And it's typically based on a series of sessions over several months. So the course of treatment might be 6 months or whatever, or less, depending on what the problem is. So I'll come back to the current dates in a minute. I'm just going to show you a formulation. This is a bit tricky, but we often draw diagrams. So I want you to have a look at this person here. The very bottom of this diagram, if you can see this person, and this is a case taken from a book by Ryle and Kerr. It's mentioned in the book. At the very bottom, this person came to see, she's a woman, her name was Beatrice, comes to see the psychiatrist or the psychologist feeling really depressed. She describes herself as being like a frozen chicken in the supermarket. She says she's like wrapped up in cling film as a frozen chicken. That's her self-image of herself. Frozen, no longer in relationships, unable to do anything, really miserable in her early 30s. That's how she comes along. What do I do? Well, antidepressants might help a bit, but actually there's something else going on. So we try to understand the story. Go right back to the beginning of her story, inside the red box. It turns out she has parents who really were quite critical of her. They rejected her and were quite demanding of her. And she felt, in response to her parents, she felt very guilty about it, but she also tried to work really hard. So she's in the red box there. She is striving and needy. Her needs aren't being met by her parents. She's quite independent. She's also quite rebellious at school. So there she's at school as a young girl. She actually gets expelled. So if you look on the side there, rebel gets rejected. Can you see that? She gets expelled from school, which just makes her feel worse. So she longs for closeness because she's an attractive young woman, makes a series of relationships. She often has relationships. She fears abandonment. She's in the centre now. She fears abandonment. She avoids getting close to her boyfriends. She feels very lonely. She withdraws from people. Her needs are often unmet. She feels depressed and she feels like a frozen chicken. She doesn't dare reveal herself. So she sometimes on the other side, on the left, is it left or right? It's this side here. She risks becoming closer to people. She tends to idealise the person she falls in love with. She makes them out to be perfect, has a moment of complete being in love, their perfect relationship. She then feels totally, she feels being worthwhile, but she fears being abandoned. She runs away again because she can't cope with the idea of being abandoned, and she's back to the frozen chicken. Sometimes on the other side, she strives very hard to please people. She pretends to be something she isn't. She hates herself. Her needs are unmet, she doesn't reveal herself, and then she feels depressed. So if you like, this is a joint collaborative formulation we've made of the kind of problems that she has. That's a formulation. Another example of a formulation here, this was a man called Terry who used to drink too much. He had very, again inside the red box, the red circle, he had very rejecting, abandoning parents who were very contemptuous of him. As a child, he's in the place of B. He's very alone, felt his needs for closeness and wanting was contemptible. And what we find in life is you often tend to reproduce psychologically some of the things your parents did to you in your attachments. So he to himself was very rejecting. He was very angry with himself. What he tended to do, again, he worked in industry. What he would find is that because he was quite contemptuous and angry with people, he'd look around at his peers and he'd often find that other people weren't as good as him. So there was, he would say to other people were, he's the best, other people would be better than him, and he would reject other people. Not surprisingly, when he did that, other people would reject him, and he would then end up being very lonely, and he would, in fact, what he ended up doing was drinking. So he would end up being very depressed. I'm the worst person in the world, and he'd drink. So he'd have a pattern of being contemptuous of others and contemptuous of himself, and he would reproduce that pattern when we analysed his relationships with others. He would constantly feel he was either the best or the worst. He had one way of thinking about people. He had to be the best of something or the worst at something. He was always winning awards at work, and then he'd win awards, he'd boast, and other people would then reject him, and he'd end up drinking. And it was a pattern he went round and round and round, and he'd find it very difficult to accept himself as he was. So that's the kind of formulation we might draw up in collaboration with the patient. And then following a formulation like that, we would then introduce ways of change. So for example, if you look at this lady here, we then talked about her sense of being rejected by others, what was about her which wasn't worthy, why she was avoiding closeness, and trying to help her to accept herself more, and gradually, therefore, to stop idealising the men she met, which she would go into a completely over-the-top relationship where she'd want to move in the day she met them, and they would then run away from her. Help her to be a little bit more careful about the relationships she got into, and gradually develop relationships where she could be with people not as perfect, without them being perfect, but more egalitarian relationship. And again, with Terry, to help him to not be so contemptuous of others, because the pattern he got into was always to put other people down, which meant they put him down. So that's what you might do in your treatment. So I'd say that's quite a different approach from giving someone antidepressants. So we might well work with antidepressants, as I say, if somebody is feeling depression. What the challenges are is how scientific is all of this. You may say, well, what's that got to do with science? We try to be science practitioners. Really, it's based on studies which have used models like this. Do they work? Don't they work? And so a lot of evidence that CBT is effective, as I've mentioned. And so there's a lot of work done. What are the studies? Does this treatment work? Doesn't it work? With which patients does it work? And one of the problems we have in psychiatry and in psychology is that actually humans are terribly varied. Everybody in this room has a different story. Doing psychological research is complicated because you all have different experiences, whereas probably most of your kidneys or livers work kind of the same, one would imagine, but your histories, your psychology is going to be so different. And we've tended to give one treatment to everybody. And what the research demands is that we have more and more nuanced treatments for different people. You wouldn't want the same treatment as the person next to you because your life story is different. And that's why often we don't get it right, because it's very difficult to get it right. Laws and medicine, if you like, I like to say that they're difficult subjects, are probably simpler because people are not so different. I mean, there are many ways in which you can be physically ill and break the law and have legal complications. But if you like, the numbers of ways in which people relate to each other is so infinitely complicated, it's difficult. And we do our best to be scientific, but we don't always get it right. Therefore, we do spend a lot of time thinking about it, and sometimes we get over-reflective and we spend our time thinking, and maybe that's not always helpful. There are not so many of us, because it's very expensive to train somebody to become a clinical psychologist, several hundreds of thousands. And so the NHS can't afford that many, and we tend to be, with a relatively few of us. Psychiatrists are much more numerous than us, and of course many more doctors. There are most mental health care, certainly in the UK, is provided through the NHS. It's provided by nurses and doctors. We're very small in number. And so how can we have, these models are very interesting, but it's hard to actually see somebody. The chances of seeing a clinical psychologist are really quite small because there are so few of us. And one of the other things is that we know very well that the things that often precipitate the background to mental health problems in particular are things like poverty and exclusion. So we know that mental health problems are much more dominant within groups that have poor resources. And if you want to improve the mental health of the nation as a whole, you might want to pay more attention to things like education and unemployment and so on, and inequalities. And we are looking at the individual victims, if you like. We get the people who have been damaged by some of those things. And maybe a better thing would be to change society as a whole, because those are the things that lead to some of the mental health problems that there are. We're fixing the individuals. I appreciate you have to do both, but often there's a tension between should we treat the people or should we try and change the system, which leads to people having these problems. We could talk more about that. And one of the other things is, could we make, you make much more better use of individual and information technology. The treatments, particularly the CBT treatments that are increasingly used, they're open to being used with technology. For example, some of the individual treatments, rather than coming to see me to do a desensitization, which is a treatment for your fear of lifts or something, could you do that online? And there are treatments which can be provided online. I had a go at this myself actually a few years ago, because there's a very good program for people who have sleep problems called Sleepio, which is a CBT online treatment. It's in fact set up by a colleague of mine from Glasgow University, now in Oxford. I don't have a major sleep problem, but I thought, well, I quite fancy, sleeping a bit better. So I did this sleep program, which meant I had to go every week. I had to go online and about an hour and answer questions and do things differently. And it was very well designed, and actually I have to say it really did work. It increased my ability to sleep well through the night, and it was very nice. The only trouble was I kind of slipped back into my bad habits after a while, which is reading in the middle of the night and things and stuff, and staying in bed late, which you shouldn't do if you've got sleep problems. But we should use information technology better to try and spread, if you like, psychological treatments to more people. And there are ways of doing that. It's very much what I think the next generation is going to include. So I think that's the next. And it'd be interesting. Here I am at Google thinking about what can we do to spread good mental health practice. We know that depression is a major cause of dysfunction in the world out there. Most of us in our lifetime will have either ourselves or one of our friends and family will have some mental health problem, and it will cause distress to families. And we can treat it medically, although not everybody responds to medication. And in many ways, what we know is that psychological treatment and medical treatment together is one of the best, but it's hugely time consuming and it's demanding and it's expensive. So is there some way in which we could deliver better treatment better? One of the things that makes it difficult is that one of the things we know is important in making the psychological treatment work is the relationship that you develop with the person you're helping. So that's very important, that we have a close relationship. How can you reproduce a relationship with a computer? Because we know that bond, the person who goes up and down the lift with me, the reason she's prepared to do it is we've spent several hours beforehand where I've listened to her, I've given her my attention, she trusts me, she knows that I respect her, I'm not belittling her, and I'm there for her, so she trusts me in order to try doing it. How could you do that, if you like, on a computer? So that's one of our challenges, how to deliver more widely the mental health treatments that we have to people. I think I've probably talked enough. I was asked to talk for about 30 minutes, I've done. Thank you.